It's upside down, it's backwards, doesn't matter what you want to call it. Triage within the current medical system is broken.
Kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
It's like we've forgotten who we are. Explorers, pioneers.
I understand how this process came about. For a very long time within modern Western society, the primary care physician was at the center of care for all things. All things. Had to be able to deliver babies, take care of any malady, set broken bones, cast, minor surgery. And then as medicine evolved, as we got into the 1940s, 50s, 60s, more and more specialization. Now we're hyper-specialized in this day and age. But I can see how triage now, with anything, in particular musculoskeletal ailments, issues, dysfunction, usually start at the top of triage, where they should start. Maybe top and bottom is maybe a bad way to say it, but we start at the most advanced versus the most conservative. So what, in musculoskeletal terms, what is the most conservative entry point? The most conservative entry point that's available to most people is going to be somebody like a chiropractor, a physical therapist, dependent on the state. And this is a separate conversation possibly on, who and who should not have open access or be, deemed primary portal of entry. In most states, chiropractors are still primary portal of entry. In a lot of states, physical therapists are. In our state of Alabama, physical therapists are actually now going, to the state to try to get primary portal of entry, so they won't have to be basically under the thumb of having to have referrals and a set amount of visits before they have to go back to get a referral from a medical physician or somebody else that is primary portal. So the bottom would be something like that. As we go up, then we're talking musculoskeletal. It could be, primary care physician. So if you're in our state and you're a chiropractor and we need imaging, we need some sort of lab work done, let's say a Medicare patient, well, that has to come from their primary care physician. Obviously, next step up would be something like an orthopedist, depending on what's going on. Now, there are non-surgical or conservative orthopedists that don't use surgery, but they usually have strong referral networks, whether it's in their practice or outside of the network, for that next step up, which would be a surgical orthopedist, which then usually gets hyper-specialized again into body parts, right? We have a hip specialist, we have a knee specialist, elbow specialist. And then I would say the highest level, which is also going to match usually some of the worst case scenarios in our practice, would be something like a neurosurgical consult or intervention. Most people don't start at a neurosurgeon, but what does happen with something like a extremely common ailment, it's going to affect almost everybody at some point in their life, of low back pain. Low back pain is going to enter the portal a couple different ways depending on age and availability of healthcare. So if you're a kid, you're going to end up at your pediatrician. If you're a somewhat seemingly healthy adult, you're probably going to either go to your primary care physician, more than likely, depending on the severity of the low back incident, whatever's going on. A lot of people actually end up at the ER or urgent care for these things. In my opinion, and talking with and actually having a nurse practitioner that works in the emergency department of a local hospital, emergency departments, urgent care centers are wildly under-equipped to handle something like low back pain. What is the typical play, whether you enter the emergency room or maybe another physician's office? It's going to be some sort of imaging, usually x-ray, sometimes CT scan if there's enough trauma, car accident, things like that. And then you're going to be usually given the general advice of, take it easy, ice, heat, anti-inflammatories. Maybe sometimes they're loaded up the whole cocktail of like high, kind of a little more potent anti-inflammatories, muscle relaxers, maybe even getting to the point of narcotics or painkillers, depending on where they go. That's usually ER play. Primary care, a lot of the times it's, we can write you a prescription for a muscle relaxer, anti-inflammatory, but that's kind of where that ends. Rarely in these scenarios, especially the ER, do you see a referral? Do you see a referral to physical therapy, to chiropractic? Maybe you go up the chain depending on an imaging finding where, hey, we see, a compression fracture on an elderly person that had a fall. We see, a disc herniation for whatever, this is kind of what we're going to talk about here in a second, is we see a disc herniation on imaging. If maybe an MRI was ordered, maybe a CT scan, which still would not be the appropriate imaging. and it gets referred to maybe an orthopedic spine specialist. We're still starting at the top. Even though you've had imaging, you would say, well, don't you need imaging? Sometimes you do, but what should warrant the imaging is the exam or the mechanism of injury. If somebody is in a multi-car accident and they're complaining of severe neck pain, they're coming in with some of these classic signs, yeah, we would get an image first, but that's dependent on each case. If somebody enters their primary care physician's office and said, my low back's been bugging me, it's like a 4 out of 10 for the past 3 weeks, and it's really bad when I drive and when I wake up first thing in the morning, I would hope that we don't just pull the trigger on an x-ray, in particular an x-ray, because that's not going to tell you much of anything, for a fairly healthy person. Now, if there's things that stick out in the exam, right? This is why primary portal of entry and the appropriate amount of training to be a primary portal of entry is key, because you do need to be able to rule out things where things could present like a normal musculoskeletal issue, like lingering low back pain that then is accompanied by worsening pain at night, maybe weight loss, all these things that we're taught in school, maybe fever, chronic infection seems like it's persistent, and then pretty soon we're like, man, I need to rule out metastatic cancer. Yeah, that's a physician, right? Physician level. It's why we're called a chiropractic physician in most states, is because you are basically deemed with that level of responsibility to make sure that things that are in your office should be in your office, things that shouldn't be in your office should be appropriately triaged out, referred out. But that does not mean that we lean on imaging, let alone non-advanced imaging. I'd say X-ray is non-advanced, advanced MRI, CT scan, things like that, to make the diagnosis for us. And there's a lot of interesting information on getting ahead of the MRI. So an article out of Health Services Research from 2015, this is kind of a review, looked at once an MRI is ordered, it costs on average $4,973 more for an incident of low back pain. And it basically just said imaging should be deemed necessary by exam, not determine diagnosis or treatment. Couldn't agree more. So what's that mean? It does not mean that you do not need an MRI, but when it means that we jump to advanced imaging, we're going to spend more money. Why? Well, you spent the money on the imaging. Then we see interventions, right, that are of higher order. Again, the triage is upside down. We don't start at the most conservative and then move up the chain to the least conservative, the most invasive. But when you do this, you don't only see money saved, which musculoskeletal disorders, MSD or MSK, musculoskeletal dysfunction, is one of the top ranking costs across the world. As I wrote in my book, Age of Movement, at that point in time, musculoskeletal disorder made up about $1.5 trillion of healthcare expenses in the US. That was per CDC data in 2019. It's probably went up. That's what I'd have to guess, because it's only going up, trending up till the 2030 intervention that the World Health Organization had tried to put in place to basically push back the tidal wave of impending musculoskeletal dysfunction. The other thing that we do see change, which just comes from a lot of retrospective studies, which are not always the greatest, to go back and ask people what was going on, how are they feeling, when something was happening. But you see in these studies, if they have early intervention, not necessarily did they have physical therapy or conservative musculoskeletal care at some point, but if they had it earlier, within the first week or 2 week of a low back incident, you saw about $1,000 saving on average for low back pain, but you also saw an increased long-term quality of life and decreased work-related spinal pain over the course of the next 5 to 7 years. Now, all that to be said, there's a time and place for every level of care within the medical profession. In my opinion, though, things like a surgery, things like even epidurals, right? Sometimes it's hard to come back from the side effects or the planned effect, the intended effect of, say, something like a laminectomy, a fusion. You might think of a discectomy is not that invasive of surgery. It's still surgery. And as we tell people going in for a procedure that you already had an injury, if you had an injury that warrants a surgery, that's a pretty severe trauma. The second trauma came with the surgery. What's wild to me is we start at the top of this chain. We may have an intervention that, is deemed necessary. And we often see with these simple, I'm air quoting, simple spine surgeries in particular, and we don't have to talk about just spine maladies here. It could be anything to deal with the human body from a musculoskeletal standpoint. But with these simple spine procedures, a lot of people are never even prescribed post-operative physical therapy, which is wild to think that, oh, you had some sort of injury, movement dysfunction, whatever was happening that led to this scenario, then another traumatic incident, whether you want to call it that or not, however they title a less invasive surgery, calling a microdiscectomy, they still are going in and pulling out part of your anatomy while you're under general anesthesia. And to think you need nothing to offset that thing's not going to happen, when we know from an evidence standpoint that the biggest indicator of future injury is prior injury, and that doesn't always mean the same injury. So just because you had a low back injury, have low back surgery, and if you don't do appropriate rehab or therapy, you can have an injury elsewhere because of compensatory movements up and down the kinetic chain. So that's, I was going to say the short of the long, but that's the long of the short, or both ways around, on why I think triage is upside down. So what would be, in my opinion, and this is just my opinion, the most appropriate process for triage? It would be starting with a conservative primary portal of entry, depending on where your state is. Why? Because we know a simple trial of care for a musculoskeletal disorder dysfunction is usually 4 to 6 visits to determine what? The actual working diagnosis of what's going on, a strong prognosis of that case's outcome, whether it's going to improve or basically respond positively or negatively. And within there, we know whether we're going to have to pull the trigger on advanced imaging, referral out for surgery, based on how they're doing. So by the time somebody hits 4 to 6 visits, they're not responding. I would hope in anybody's clinic, in any conservative musculoskeletal practitioner's clinic, they're hitting the pause button. Do I need advanced imaging? Do I need a referral? Do I need a second opinion? That's what should happen. As we go up the chain, having strong referrals within this triage network to know that the appropriate move is not necessarily always just surgery, right? Sometimes we do need epidurals, we do need injections, we do need advanced imaging, we do need other biologics and therapeutics that can be a integrative approach to functional rehabilitation. So if you started backwards in the triage system, or that's what you've kind of been indoctrinated to, next time something happens, just think about what are the other options, because as you've heard the old adage, if you're a hammer, everything's a nail. If we go to the highest level of care first, and my intervention, not of choice, but my intervention that I've been trained to use in the lens I look through is surgery or medication, whatever it is, that's what you're usually going to get. Ideal world, every physician you are going to is doing a world-class exam, which then determines, should I be treating that person in my office? Should I be referring them out? Should I be, triaging them, but still maybe being at the center of care, playing quarterback? But I hate to say this, that's just not happening in our medical infrastructure in this day and age that often. So that's what we pride ourselves on. Anybody that we refer to is of that same mindset. And I just can't say how important that is to seek out a proper exam, somebody that's actually going to talk to you, explain what's going on, give you all the options, lay out the short term and the long term, and have all the information before you make a decision, especially a decision you can't go back from. Thank you for tuning in. Please subscribe via YouTube, Apple Podcasts, or Spotify. If you like the message, please share it. We appreciate it. Thank you.